Hello everyone, I'm Gabriele Bellio and together with Enrico Marrano we are Surgical Pizza. We had the following talk during the Association of Women Surgeon Europe Conference 2022. The topic of this presentation is Education on a Neglected Branch of Surgery. For those of you who do not know us, Surgical Pizza is a website in form of a blog page created in mid-2020 by Enrico Marrano and me. The two of us had our residency programs in two different hospitals. Enrico had his in Verona, I had mine in Trieste, both in the northeastern part of Italy but about 350 kilometers apart. However, our surgical training was very similar. Both of us spent several months in the trauma unit of the Chris Hani Baragwanath Hospital in Johannesburg, South Africa, and both of us worked in the emergency surgical department of the Humanitas Research Hospital in Milan. As you may have noticed, Surgical Pizza was created during the first wave of COVID-19, and it is not a coincidence. In fact, we had some spare time due to the closure of the operating rooms. So we wanted to invest this spare time trying to find a way to spread knowledge on acute care surgery. So what is acute care surgery? I bet that most of you did not even know about its existence until now. It is a relatively new branch of surgery focused on the management of patients affected by acute surgical problems. This subspecialization aims to create surgical figures able to cover the on-call shift 24/7. And it is the answer to our realization, and this realization is that acute surgical pathologies must be treated by specialized surgeons in the same way as elective surgical pathologies are managed by specialized surgeons. After all, if you have a colonic cancer, you go to a colorectal surgeon. If you have breast cancer, you go to a breast surgeon. But if you have acute appendicitis, you just go to the hospital. And the one treating you may be a colorectal surgeon as much as an endocrine surgeon. And this lack of specialization means worse outcomes. More, there is a major difference between the management of an elective patient and an acute surgical one. In the first case, you need to focus on the anatomy and the pathology. In the emergency setting, you must always think about physiology first. Taking a quick research in PubMed about acute care surgery gives back about 3,500 results, the first of which goes back to 1986, not at all. However, reducing our time frame of research between 1986 and 2005, we only find 5 results. And looking a little bit deeper, particularly to the paper published in 1986, we find out that it is not about acute care surgery at all. So the first published paper talking about acute care surgery goes back to March 2005. And it is basically a statement paper by the American Association for the Surgery of Trauma, the WAST, underlying the need for a surgical figure who is able to manage all surgical emergencies, both in the operating room, in the emergency department, and in the ward. One more interesting thing about it is where it was published. The name of this journal is the Journal of Trauma, Injury, Infection, and Critical Care, and that's not interesting at all. The interesting thing is that few years later, this journal changed its name into the Journal of Trauma and Acute Care Surgery. This is to give you the idea of how much importance acute care surgery was and is gaining, at least in the States. Well then, what is acute care surgery in practice? What does it include? You recognize for sure these 3 branches of medicine listed here: trauma, emergency general surgery, and surgical critical care. Trauma is quite straightforward and it involves the management of a traumatized patients, those who sustained a car accident or who were stabbed or shot. Emergency general surgery includes the management of renowned pathologies such as acute appendicitis, acute diverticulitis, bowel obstruction, and so on. Surgical critical care is basically the medical management of surgical patients. These 3 groups altogether form acute care surgery. However, in the last few years, one more branch was added, and this branch is the so-called rescue surgery. Rescue surgery is basically the management of surgical complications. For example, You are a colorectal surgeon and you perform a colonic resection for colonic cancer. During the postoperative period, your patient develops an interatmospheric fistula. Now, you may have two clinical scenarios. The first one is that your patient has a low output, not complicated endoatmospheric fistula, and in this case you can manage it on your own. Just watch and wait, and the fistula will most often heal by itself. The second clinical scenario is that your patient develops a high output complicated enteroatmospheric fistula. And in this second case, you may not be able to manage it by yourself because you don't have the experience, you don't have the expertise, and you don't have the equipment to do that. So in this case, you need someone else to treat this patient instead of you, and this someone else is an acute care surgeon. This is a draft plan for an acute care surgery fellowship training program proposed by the AWS, and this fellowship program was formalized in 2007, and in about 10 years 20 fellowship programs were born in the States, so quite a few. What I want you to see here is how the training is structured. This is a 2 years program, and about half the time is spent in critical care units, where the other half is in different specialized surgical departments. And the reason behind this is that an acute care surgeon must be able to deal with basically all surgical emergencies, even neurosurgical ones. However, acute care surgery is still neglected and not recognized as a real branch of general surgery in many countries. This is mainly true in Europe and particularly in Italy. This resistance to accepting this new kind of surgery lies in the past. In fact, once there were the so-called omnipotent general surgeons who were able to deal with basically all kinds of surgical procedures. Nowadays, due to the creation of highly specialized surgical units, these omnipotent surgeons do not exist anymore, and the young surgeons are more attracted by organ-specific surgeries, such as colorectal surgery, hepatobiliary surgery, breast surgery, and so on, and this leaves trauma and emergency surgery with no one to deal with them, or better, with everybody dealing with them, but this means not specialized surgeons managing acute surgical pathologies, and this leads inevitably to worse outcomes. But acute care surgery is very important. Look at how much trauma burdens the overall death in Europe. And the same, maybe even more, happens in the States. Here you can see that trauma is at least one of the top 3 leading causes of death in the age groups from 1 to 59 years old. And changing our focus from trauma to emergency general surgery, we can see how the incidence and prevalence of admissions due to acute surgical conditions exceeded those of more noble health problems, such as diabetes, coronary heart disease, and cancer. So this is quite huge. The impact of acute surgical problems on the general population is huge. However, even in the States, emergency general surgery has been neglected for many years in face of a huge number of admissions and surgeries performed. In just 1 year in the States, more than 3 million patients are admitted because of emergency general surgical diseases, and about 1/4 of them require surgery. Now, the most important question is, does the development of an acute care surgery plan improve patients' outcomes? Because acute care surgery works only if it gives back better outcomes. Otherwise, we're just talking about nothing. And the results of this study seem to support this hypothesis, reporting that after the introduction of an acute care surgery model, the mortality due to the emergency general surgical pathologies decreased by about 30%. And this is a great result, supporting the fact that acute care surgery is useful. However, as we said before, young surgeons are not attracted by this specialization, so the main problem now is how to increase interest in this neglected branch of surgery, how to make young surgeons choose this path. And to create interest, you need to spread knowledge, and a possible way to achieve this is the use of social media. In fact, the interest in social media as a possible and useful way of spreading surgical knowledge has grown over the last few years, as you can see here in this graph reported by PubMed. In our opinion, to create interest, you have to choose carefully your audience and your way of talking. We at Surgical Pizza have chosen a specific way of teaching, and it is not original, we have to admit it. On the contrary, is heavily inspired by two great books. The first one is Top Knife by Professor Kenneth Mattox, and it's about trauma. And the second one is Shine's Common Sense by Professor Moshe Shine, about emergency general surgery. And similarly to them, we mainly focus on the youngsters, medical students, registrars, and young surgeons. We prefer to use direct language as if we were talking directly to our readers. We use social media for many purposes to spread our productions, to increase our audience, and to use different forms of communication. In fact, as you know, each social media has its own way of communicating the same thing. For example, Instagram has images, Twitter has brief sentences, TikTok has videos, and so on. Most importantly, we want to give straight to the point messages. So our posts are brief reviews of the literature, leaving behind all the non-fundamental concepts. So what we are trying to do is to break the mold of usual education. To conclude our brief talk, we have to accept three concepts. First, medical training and residency programs are not always providing appropriate education, both theoretical and practical. And this is mainly true for some neglected branches of medicine and surgery, such as acute care surgery. And this leads to two consequences. One is that young doctors start to look for alternative sources of self-education outside universities and hospitals. The second one is that we risk finding ourselves in the future without specialized doctors in these branches, and this will lead to worse outcomes. The second concept to recognize is that education is changing, or better, the educational ways are increasing in number. Once there were only books and papers, today we have websites, social media, webinars, podcasts, and so on. And these new forms of education are more easily and readily obtainable. Just think about how much a single paper costs. Also, they are more immediate. You don't have to spend hours reading papers of chapters of books. You have just a single shot with all the information you need, all the notions you are looking for, already filtered, already prepared, just for you to take in. So this is to say that today education comes first through different channels than books and papers. And this is normal evolution, but we have to accept it. The third concept is that if you want to educate, you need to create interest in what you are talking about. With all the contents and the information floating around us, our attention threshold has decreased substantially. So you must be different, you must be original, you must be constant, and you must create fidelity. And we, at Surgical Pizza, hope we are doing a good job. So if you want to follow us, here are our platforms, and thank you all for your attention. See you next time.